three categories. The first is they may be having a normal ejection fraction above 50, so half F, and they have a sign symptom of heart failure. Another one is reduced ejection fraction less than 40, and in the middle 41 to 49. Now these patients being treated. After treatment, they come up in 3 months follow-up, we reassess them, or 6 months, we reassess them, and they do the serial and assessment and echocardiogram. Now the reduced ejection fraction might be still remain in reduced or may have gone to improved ejection fraction. Mildly reduced may go to reduced, deteriorate, or may remain same or may improve. Similarly, the one with the preservation fraction can reduce, go to -40 or mildly improve or preserve. Treatment is based on this, which we are going to next few slides. Now, this was given 2022 April, just few months back guideline. But the European Society of Cardiology also came out with their guideline in 2021, more or less same, divided into the three group based on echocardiogram, ejection fraction of the patients less than 40, 41 to 49, or more than 50. So this is, we call it guideline-directed medical therapy. And what is this guideline-directed medical therapy is, this is, we do the clinical assessment, patient comes, history is taken, what is the cause, why did it deteriorated, is there any exposure of toxins, physical examination, ECG was done, laboratory tests were done, and end up with the natriuretic peptide. If the NT-proBNP is more than 125, this suggests the congestive cardiac failure, or BNP is more than 35, suggests congestive cardiac failure. One of the best baseline investigation is transthoracic echocardiography, and this will decide the patient has a reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction, and they go for the guideline-directed medical therapy. And the guideline-directed medical therapy came out with the Fantastic Four. And what is this Fantastic Four? Which is base of our heart failure treatment. These can be started together or sequentially. ARNI, MRA, beta blocker, and SGLT2 inhibitor. These patients might also be the anemic. So we look for the anemia profile. They may need ferric carboxymylase. They might be having atrial fibrillation. They will put on anticoagulation digitalis. They might be having a LBB or dysfunction of the left ventricle, can need CRT or CRTD. Similarly, they might have a lot of volume overload. They may need loop diuretics. They may decongestion. They might need devices to. They might need another control to control with if they are not controlling resistant hypertension, to add with the hydrazine. So different mechanism and different treatment. Let us go one by one. So guideline-directed treatment says that these four are the basis, should be given, and they have shown remarkable improvement in morbidity and mortality. The first one is renin-angiotensin system inhibitor, which include ARB, ACE inhibitor or ARB. Second is beta blockers. Third one is MRAs, which is mineralocorticoid receptor antagonist. And the fourth is SGLT2 inhibitor, which is sodium glucose cotransporter 2 inhibitor, which include empagliflozin and dapagliflozin. These treatment can be started simultaneously with low dose and then increasing dose gradually with the response of the patient, or sequentially seeing the response. So this treatment should be tailored patient by patient, seeing his clinical condition, how worse he is in clinical scenario. So ARNI is one of the most important, which is called angiotensin receptor neprilysin inhibitor, which is a combination of the two drugs called sacubitril and valsartan. This drug has been marketed in last 3 or 4 years and marketed called as Entresto. When this drug treatment, which is going on for last 10 to 15 years, came, and they have shown remarkable reduction in morbidity and mortality in all majority of the patient with NYHA class 2 to class 3 symptoms. And this is after reducing their morbidity mortality, they labeled as a class 1A in this group of the patient. This is recommended, especially initially these patients were being treated by ACE inhibitors and angioreceptor blockers. These are still being used and treated, but if they are not responding adequately, or if the patient has worsening condition, it is always better to replace ARNI. Beta blocker is another group of medication which is in use to treat heart failure for the last 2 or 3 decades. They came out with a newer generation of beta blocker which is remarkably far superior and better. And these new generation are 3 of them: bisoprolol, carvedilol, and sustained release metoprolol succinate. They have shown categorically in all study reducing the morbidity and mortality class 1A. Similarly, neurocorticoid receptor antagonist, which include the spironolactone and amiodarone, they have shown to reduce morbidity and mortality. When we are very careful that their eGFR or kidney function should be better and maybe more than 30 ml per minute, as well as their potassium should be less than 5. And this is the recently added group in last 2 years only, SGLT2 inhibitor, because sodium glucose transporter 2 inhibitors include empagliflozin and dapagliflozin, very commonly used these drugs in diabetic patients. But very interestingly found that the congestive cardiac failure patient with NYHA class 2 and class 3 with a reduced ejection fraction, all this group has shown irrespective patient is diabetic or not diabetic, their heart failure improved. This is class 1A. So in the management strategy, patient comes, being investigated, found out if he has a reduced ejection fraction, goes with these fantastic 4. If he has a volume overload, patient receive diuretic to reduce his volume, and then patient receive ARNI, beta blocker, MRA, SGLT2 inhibitor, plus minus diuretic as we just mentioned. Now these patients after the treatment might improve or they may persist. If they improve, we can further follow up according to the guideline treatment. If they remain or persistent, not improving, then we should look whether they are from a Afro-American patient or they are having deterioration in their heart failure and now ejection fraction less than 35. Then what we do, we categorize with another drug of treatment. So hydrogen nitrate was added if they are Afro-American, and if they are still not improving, ICD has been shown remarkable difference and they protect them from sudden death due to ventricular fibrillation. And if they are not having a left bundle branch block with QRS duration by more than 120 to 150 millisecond, they have shown remarkable improvement by CRTD, which is showing that reversal of their desynchrony in the left ventricle. It may happen the patient may improve after this additional therapy, followed with the guideline, but they may not improve. So they become refractory. Here what they say, we refer them to our team to cardiac transplant, or they go for a left ventricular assist device, where they may improve or their symptoms may improve with these things. Also they can go for investigational drugs or palliative treatment depending on case-to-case basis. To journey from here to here, in worst cases, do not take more than 5 years. 5-year mortality is very high. Those who are in my case, they may improve somewhere here and can live for 10 to 15 years without any problem. So they said we are using these expensive drugs which came recently, how is their market value or how is their value for the money? They all have did many multiple analysis and they say all showing high value, grade category A, whether it is RD, ACE, or ARB, beta blocker, MRA, and intermediate for SGLT2 inhibitors. Now what they have seen, if we give one drug, which was started as a beginning, if we give only beta blocker, we can get improvement nearly 40%. If we get combined beta blocker with ACE or ARB, not together, only ACE or ARB, then we get about 60%. Combining with ICD or other treatment modality, we can get benefits close to 80%. So strategy is to apply all these fantastic four together. This is a famous study, empirical study, which has shown selectively that empagliflozin and dapagliflozin in another study has improved the cardiovascular outcome in patients with reduced ejection fraction and heart failure. They also have shown improvement in the renal events. So in this graph, if you see, they have shown remarkable improvement with the drug compared to placebo, whether it is a congestive cardiac failure, in reducing the death and the hospitalization, whether it is in a renal endpoint, improved by the empagliflozin. Therefore, this drug now has been recommended irrespective patient has diabetes or no diabetes to add it in the treatment regime of the heart failure. They are also very good in controlling the blood sugar, but not very significantly. But yes, they control about reducing HbA1c by 0.5 to 1. So what is European Society of Cardiology, they are agreeing or not? So they will go to the European Society of Cardiology and surprised to see that they also have same regime, same thing, fantastic for ACE, beta blocker, MRA, SGLT2, diabetic with other categories of CRTD, ICD and other management plan. Similar thing has been adopted by Canadian guideline, same four group, and they also says that they strongly recommend that the ARNISH can be replaced with ACE and ARB, because what has been seen in later part of the studies which came in last 2 years, that patients, those who are still having symptoms or still not improving, when we switch them to ARNI, they will start improving remarkably. And the patient goes home, they will not come to the hospital and says, oh, I never thought that I can be functional with this drug as we are seeing now. This is another famous study, RAILS, published in New England Journal of Medicine, showing about MRA. This independently, so is whether it is a spironolactone, which is compared with placebo, shows significant possibility of survival, and it is a survival. It's not just symptoms improvement, or whether it is a emphasis heart failure study with eplerenone. Both have shown significantly reduction in morbidity as well as mortality and survival rate. So what is recommended that all these drugs have shown very good in reduction in mortality and readmission due to heart failure and improved survival. Whether it is ACE inhibitor, which has shown 16%, beta blocker 34%, MRA 30%, ARB 17%. So in 2022, guideline update, let's say, okay, patient might be having a reduced ejection fraction, might be having an intermediate, and might be having a preserved ejection fraction. So what we will do? So the patient comes with a congestive cardiac failure symptoms. Patient, if used with the ARNI as symptoms of class 2, class 3, it is class 1 indication with level of evidence A, which is very good in reducing mortality. If patient cannot afford or is it not feasible to give ARNI, patient should be on ACE inhibitor. Again, class 1 evidence of A. If patient cannot have ACE inhibitor because of angioedema or something, they should go for ARB class 1A. All these patients should be started with these medication in the beginning. So as we said, we just spoke about the reduced ejection fraction. What about mildly reduced ejection fraction? Same, 4 group, if they are volume overload, give diuretic, SGLT2, ARNI with ACE or ARB, MRA or beta blocker. If they have preserved ejection fraction, same 4 group, diuretic, SGLT2, ARNI, MRA or beta blocker. Now these group of the patients have shown remarkable difference irrespective of reduced ejection fraction or preserved ejection fraction. Their heart failure improves and their readmission rate goes down significantly low. This the same guideline is read. So this new drug which has replacing now ACE or ARB in cases of congestive cardiac failure is a combination of sacubitril and valsartan called Entresto. So what we have achieved? What we have achieved in reduction in all-cause mortality? ARNI or ACE or ARB have shown reduction by 25% in 2-year mortality. Beta blocker has shown 16% reduction in 2-year mortality. Aldosterone antagonist has shown 2-year mortality reduction by 11%. SGLT2 inhibitor, 9.5% reduction in 2-year mortality. This drug has changed the scenario of congestive cardiac failure at a clinical practice. They also have shown that by combining these four and starting as a first-line treatment, the rapid improvement in the health status within 4 weeks, within 4 to 8 weeks, rapid reduction in heart failure, hospitalization in 2 to 4 weeks, reduction in mortality in 2 to 4 weeks. Many of these patients used to die within a month or 2 months. Rapid improvement in heart failure in 12 weeks, rapid reduction in rehospitalization in 4 weeks with improved tolerability, adherence, and the patient has seen a much better life. So ladies and gentlemen, in summary, what we have just spoken, we should go for 4 pillar of Fantastic Four as a guideline medical therapy for these cases of congestive cardiac failure. Now I am sure that this army is also available in India, Indian scenario, and being used, maybe it is a bit expensive. So combination of army, beta blocker, MRA, SGLT2 inhibitor is a class 1A. And what we recommend that this drug has been shown repeatedly, like we said, that is angiotensin receptor neprilysin inhibitors, which is an interest of reducing the morbidity and mortality in these patients. Beta blocker, again, whether it is a bisoprolol, carbidopa, or metoprolol, succinate, have shown prolonged effect and with reduction in morbidity and mortality. Mineralocorticoid receptor, similarly aldosterone or spironolactone or eplerenone, they have shown reduction in mortality and morbidity in patients of heart failure. Similar goes with SGLT2, sodium glucose co-transporter inhibitors, and dapagliflozin, which is a lot of patients are taking as a diabetic, giving much benefit in reduction in heart failure. Thank you. Though it is a pure clinical scenario, I'm sure that you are happy to ask some question.
Wonderful. I think it was very relevant talk. Those who were following it, and also in relation to the experimental work which has emerged from so many different continents, and now these are all both the guidelines, very much similar, the European and kind of consolidate, I think, guidelines between US as well as Europe. If you allow me, can I ask you a question?
Yeah.
Yeah. Now, we heard also on metabolic syndrome and relevance in the northern part of India, what Professor Lindsay Brown had mentioned. Also, our lifestyle, cultural things, can they be comparable to some or all
Yes.
the guidelines which are there in Europe? And
Yes, so there is a separate guideline. There is a separate guideline for cardiac, what we call as a cardiac physiotherapy or cardiac therapy plus prevention. So in a prevention heart failure, there is a class 1A indication of rehabilitation, cardiac rehabilitation, diet, lifestyle, and it is shown that the first management should start the moment patient is admitted to change his diet pattern, to change his fluid pattern, to change his lifestyle, and to improve his cardiac rehabilitation, walking 6-minute walk. Our cardiac rehab team comes, take the patient, take all the parameters on his bed with pulse oximeter, oxygen, make them walk for 6 minutes and do the assessment. I'm sorry I have not included those slides in my talk, but they have a very important role to play. Whether it is in the beginning, whether it is in a prophylactic or in prevention part, or whether the patient has already class C or class D congestive cardiac failure as a rehabilitation part. At all level, they have got this role.
Excellent, excellent. I will leave the floor to others to ask questions and comments. Professor Brown, do you would like to add something or comment?
Thanks, Harry. My question was going to be the one that Dr. Misra has just answered. Thank you. I need to ask him now. Thank you.
Yeah, I think I need to question.
Yeah, only issue is, in fact, I will probably ask your team and Professor Brown to give us a specific, like a lot of patients ask, Doctor, which fruit I should eat, which food I should eat to improve my heart failure or to improve my angina or to improve my metabolic syndrome. So normally as a guideline from HASC which we follow, or otherwise we say we should have at least 5 servings of fruits, a big bowl every day, and it has shown significant reduction in blood pressure by 5 to 6 millimeter of mercury, reduction of weight by 5 to 6 kg within 3 months time. But we don't know we should mention particularly you eat this fruit, it will give you much better. So if that we can get information is much beneficial.
That's a very good question. And I mean, I would, from our work, go and say anything that's purple coloured fruit. So the anthocyanin containing fruit. But also what that doesn't take into account is that as soon as someone starts on that sort of extra fruit, they will do other things like decrease their alcohol intake, decrease their smoking, walk upstairs more often, maybe even do a little bit, walk around to talk to the neighbours. So all of those things, they will say, oh no, we haven't changed a thing, but they will. And so getting them onto that active one of fruit intake will also increase a lot of those other good things as well.
Yeah, thanks. Actually, this is always in my management. First 10 minutes, I always talk about the lifestyle management. And luckily on 29th September, this month, after a few days, 4 days, is a World Heart Day. And all talks are there, many talks I am taking on that day, on lifestyle and how to manage your diet and lifestyle and exercise program. Purely, no medicine, I am talking on that day.
Wonderful. Wonderful. That's it, Dr. Saxena, Kapil.
I would like to please go ahead.
Please.
Dr. Kapil, please go.
So my question is,
Yeah, good morning. So,
can you put on your camera? Can you switch on your camera?
yeah, it is on only.
We can't see you. It's hidden somewhere.
It's all right, we can hear the question.
Now we can hear the question, please.
Yeah.
Now we can hear.
Second, regular exercise. Third one is statin. They all have shown that your plaque become very stable. If the plaque is thick and stable, even if it is 80% block, doesn't matter, it will not rupture throughout your life, you will not have heart attack, and you will not have any problem. The heart failure, nor the heart attack, nor the liver. So strategy should be based on the diet, lifestyle, and statins. Aspirin has been removed now. There is no way of aspirin as a prophylaxis. Last 3 years, our guideline says if it doesn't have coronary artery disease, doesn't have PCI or COPD, don't give aspirin. Wonderful.
Can I ask one question?
Wonderful. Okay.
One question from
Yeah.
my so Dr. Misra sir, I'm working at Leh Ladakh area and I have been frequently traveling for longer periods and all that. So I have seen so many people suffering because of the environmental hypoxia which is there. So people go on oxygen therapy and frequently lot of army people as well as tourists. And I myself have been couple of times admitted and have been on oxygen therapy. So one question just comes to my mind every time I look at my oximeter and my oxygen saturation drops down to say 85%, 80%, then I have to, look for oxygen therapy. And after 2 days time, I'm okay and I can get back to work. But the question which comes to my mind is how much risk is too much risk? And how much duration of an hypoxic exposure to a human body under this situation is sustainable? If a person is normal, it doesn't have any pre-existing comorbidity and like a diabetic or a high cholesterol, like somebody like me who's my parameters are absolutely fine. So just this question comes to me that okay, 24 hours or 48 hours, or how much one can risk, and whether that assessment, sometimes that assessment goes wrong and you end up in a bigger problem.
Yeah, it's a very interesting question. Actually, this is entirely based because the oxygen concentration is low in Leh Ladakh area. So what it happened, it triggered in our body in a hypoxic stage.
Yeah.
Now, whenever we go to Leh Ladakh, like when we went with also Professor Hari, there is a mandatory acclimatization for minimum of 24 hours in a healthy heart. Here we are talking about a healthy heart. Minimum 24 hours. The one with the diseased heart, who already have a pulmonary hypertension, or has a chronic obstructive pulmonary disease, or has a COPD, bronchial asthma, we are talking on the right side of the heart now, which is directly linked with our lungs. So in any of this situation, his acclimatization will be more prolonged and he may not be as active as a healthy heart, who doesn't have any of these clinical conditions. Now, what actually happens when we get hypoxia in the acute phase and the chronic phase? There are two elements. Those who are going from the plane, going suddenly, they deal with the hypoxic situation, need acclimatization, and they have to go slow because they are not yet adopted. A second situation, those who are already living there for years and ages, and they say, well, I have no problem, I can climb even mountain. So that is called adaptability of our body and the heart. It does in the two ways. One, it improves the pulmonary pressure and circulation in the lung by again changes in endothelial lining and perfusion changes. Second, hypoxia trigger our bone marrow because the brain is sensing we have low oxygen. So brain gives the instruction to the bone marrow to produce more hemoglobin.
RBCs and hemoglobin.
So the mechanism is the bone marrow started producing more hemoglobin because hemoglobin combines with the oxygen carrying to the tissue. So all these patients who has a chronic still there, the hemoglobin goes to 17, 18.
Yeah.
So this
sometimes
is
even it crosses 20, 21 and they have to donate blood because of too much of
exactly. If it goes that high, it increases the risk of coagulation, formation and stroke.
Yeah.
The moment it crosses 18, we always send them for venesection and just remove the blood.
So the question exactly was, I was just wondering that how much duration of hypoxia one should risk with, that kind of, although it may be a vague question that it varies person to person and...
time after it was indicated, I think the hemoglobin check could be one of the criteria, I think.
Yeah, that is for prolonged duration. Yeah. Thank you so much.
So hypoxia with pulse oximeter should not go down below 90. When we say 90, it is in our body already about 65%.
Yeah, in the cold it is much
It is
lower.
not linked with the blood level of oxygen. It shows the pulse oximeter.
Yeah.
So any person less than 84 is serious. So pulse oximeter criteria, it should be above 90.
I think we are running short of time. We are already.
Dr. Saxena, Professor Saxena, please.
I'm telling that we are.
Shall we conclude, Dr. Sahab? आपकी आवाज नहीं आ रही है।
आवाज नहीं आ रही है भाई, देखिए।
Yeah, so is this my turn now?
No. Dr. Saxena there, आपकी आवाज नहीं आ रही है।
नहीं आवाज आ रही है, देखो नहीं आ रही है।
Okay, I think the next speaker. would be there.
8 minutes is there, sir. 8 minutes. Can you hear me now?
May I take a leave because I have
Yes.
to go some.
Yeah, you can please take your slide.
I'm going to miss some important, very interesting lectures.
All right, thank you so much.
But just one thing.
Thank you very much,
Just one
Dr.
thing.
Brown,
Just one thing before you
Dr.
go.
Kapil Kapoor,
Just
Dr.
one thing
Misra.
before
It
you
was
go.
so lovely to see you all,
Yeah.
and you guys have really done great session. I'm very delighted that everything went so very well. And we will let the session continue with other speakers and whosoever will.
Thank you very much.
Good night.
अभी तो श्वेता
Shweta is next. Right next is Hari.